Hello, everybody. I'm back, and it is time for part 2 of the diabetes lecture. Okay, we were getting into some of the meaty nitty gritty here with the treatment and how powerful prevention can be. And so let's keep rolling along here. Let's talk a bit about medication management. For people with type 1 diabetes, if their pancreas has failed and is just not producing any insulin, they are going to have to rely on insulin injections. The oral hypoglycemic, so the oral will be taken by mouth, the hypo, meaning they pull the glycemia down when it's hyper, would be things like metformin, which is one of the most commonly sold prescription medications in the US. The oral hypoglycemics can be used for type 2 diabetes unless it's just not controlling glucose levels nearly enough. And some of those individuals in type 2 are going to end up on insulin and becoming dependent on insulin also. I want to talk about the fact that insulin is a protein chain. So the pancreas produces it, releases it into the bloodstream. It serves that carrier molecule as a carrier molecule, brings the glucose into the cells. Insulin itself is a protein chain. And insulin injections, they're liquid, and we get our insulin from dead beef, dead pork, human insulin, dead people, or synthetic insulin. It's liquid. It has to be injected into an area of the body. Usually it's injected into the abdomen or the hips, kind of the fattier areas. It's not injected right into the bloodstream. But I want us to think through, as a protein chain, why can't people drink their insulin, which would be much more pleasant than having to do an injection. But if they drank it as a protein chain, by the time it gets digested, it's going to only come out in the single amino acids in the bloodstream. And it's not going to be the amino acid combination of that protein chain. And it wouldn't function. It would not be able to serve as that carrier molecule. And so people can't drink it. Most people who are on insulin, I've got a little picture there of a glucometer where a person has pricked their finger, dropped a drop of blood onto the glucometer strip, and then it's going to give them very quick feedback about where their blood glucose levels are riding. And ideally, a person with diabetes who manages it very tightly is checking their blood multiple times during the day. So as an example, checking it before bed, before they're going to be fasting all overnight, checking it before they engage in more intense exercise, as an example. Ideally, they're checking it over and over and over again. And then given whatever the results of glucose levels on the glucometer are behaving in a way to try to maintain tight control. So eating if they need to eat, injecting insulin if they need to inject, all of that kind of stuff to try to help them with tight control. But I want us to just back up here a bit from a psychological standpoint here, because we've already talked about how absolutely critical behavior is, especially for getting type 2 diabetes, type 2 and type 3. Oftentimes there are things people can't control and how they get that type 1. But psychologically, here we are simply talking about, here this person who's oftentimes had not very healthy lifestyle behavior gets diagnosed with type 2, type 3 diabetes. And then now we're saying, hey, you really need to have tight control, because if you don't have tight control of your glucose, you're going to get sick. You're going to go blind. You might have to lose your foot to gangrene, all that kind of stuff. But here's what we're asking you to do. We're asking you to cut back on your eating. We're asking you to start exercising. We are asking you to prick your finger multiple times a day and drop blood on this glucometer strip. Depending on what you get there, we're asking you to inject insulin. And add to that, we've got an issue in the United States that our access to insulin is much more expensive than access to the cost of insulin in our sister countries that ration healthcare and have socialized medicine. So not only asking people to do positively punishing behaviors over and over again, oftentimes it's also a financial burden. Okay, financial burden, and it doesn't feel good to prick your finger and get blood. It doesn't feel good to inject insulin into parts of your body, as an example. So it's no wonder when we start thinking through it that way from a psychological level, why so many people who've been diagnosed with diabetes, either they can't afford to use their medication like they are expected to, or even if they can afford to use their medication, it hurts. It just hurts. And positive punishment meaning the behavior oftentimes decreases. We've got a huge issue for a lot of our diabetes patients who are not adhering to their medical regimen. They're not taking their meds and their insulin like they're supposed to be doing. And then therefore their health is going to pay. They're going to have consequences in the future because of that, which is why it's important for psychologists to be on board in these medical settings. There are a lot of nowadays diabetes nurses who just specialize, nurses who specialize in counseling patients on how to follow their medical regimen, learning, what are the best places in your body to inject insulin. I do want to make a comment here before I leave this page, though. The oral hypoglycemics, they tend to help the insulin be more efficient and not as resistant, but we can get that efficiency in that insulin. We can get that very same effect with exercise, because one of the things that happens with exercise, imagine muscles are moving over and over again. They are demanding insulin, and the cells are demanding energy to be able to move over and over again. And the mechanics of all of that become more efficient if we train it. It's like a training effect from exercise. And people who are sedentary, they have not trained that benefit. And so their insulin oftentimes just becomes very resistant, and it's wonky, doesn't work very well. Okay, so we talked a bit about the self-monitoring with the glucose. And again, I said multiple times a day here, we're saying about I got a picture of her words here, but I can't move it right now. Another way is for individuals to afford these devices that are these continuous glucose monitors. There's research going on where they can look at these devices where they actually shine light through fingers, and they're able to tell glucose levels through that type of stuff. Some of those pieces of equipment might be available in the market, but it's much more expensive than the old-fashioned glucose monitors. The nutritional guidelines, I've got down here at the bottom, myplate.gov. And if you all want to go onto that website and take a look at that and play around with it, you can even plug in and do a dietary screening for yourself of what your typical nutrition is like, and then what it says about your health. But the food pyramid that is high in whole grains, fruits and vegetables, pretty low in protein and dairy for the recommendations, is a good nutritional program for people with diabetes, trying to prevent diabetes, or people trying to treat their diabetes. People with diabetes have to be especially careful with animal fat because of all the cardiovascular risk from the diabetes. They also have to be very careful about consuming simple carbohydrates. Now, carbs get a bit of a bad reputation in US culture. It's simple carbs that aren't healthy. It is the complex carbohydrates that we get naturally from whole grains, legumes, vegetables. A lot of fruits have simpler, but still better than if we're consuming processed foods that have processed corn syrup, sugary cereals. All of the stuff with the simple carbs is not real healthy for any of us, but is especially concerning for people with diabetes, because consuming simple carbs is going to spike their glucose levels very quickly. And it's oftentimes consumed in food that doesn't have many other nutrients. So the foods with the complex carbs, much, much healthier to consume than the foods with the simple carbs. We've already talked about how that 7% weight loss in obese individuals compared to the placebo and compared to the metformin group showed a risk reduction of 58% over 3 years. And so attention to diet is going to be critical. But again, we're oftentimes talking about individuals that have pretty rough lifestyle in the first place, which is how they arrive at type 2 diabetes, having challenges being asked to create this dramatic lifestyle change after the diagnosis. Exercise, absolutely key to training that insulin efficiency, absolutely key to helping people build muscle, lose body fat, absolutely key into cardiovascular health. And so it makes some sense. We don't see this a whole lot in the US, but taking people who are type 2 diabetes, who are at risk for having stroke or heart attack, trying to get those people into a prevention cardiac rehab program, get that medical supervision, get into that rehab program, help those individuals change their lifestyle. And in theory, all cases of type 2 diabetes could be treated, could be prevented, could be treated, with intensive lifestyle change. Okay. So we've talked about how, we're about 9.3% now. We're going to be up to about a third of all Americans by 2050. This is one of those places where we should be sounding alarms that this is really an issue for people in the United States. We really need to be focusing on this and helping individuals make these lifestyle changes. The education and modeling piece to it, again, this is what a lot of these specialized nurses are doing. Psychologists who are involved in the diabetes field do a lot of this kind of stuff. Of being able to educate people, help them understand what's going wrong in their bodies, understanding that normal homeostasis, what tight control means, where their body's going awry, how to try to manually take care of the things that their body can't do for them naturally. And then the modeling piece, we've seen there's some really fun research with, especially with kids. If kids can work with a role model, an older kid who has adapted to their diabetes and has been able to show a younger kid, like, well, here's what I do when I go to a birthday party and there's cake and pizza and sodas, and that's all they're serving for kids to eat. Here's what I do to manage those kinds of situations, as an example. Younger kids love it when they've got older kids who are able to model for them and teach them how to do things even better than adults in a lot of situations. So the role of psychologists, and there are quite a few clinical health psychologists who this is their specialty area. They're in these med centers or they're in primary care, they're doing research, they're serving clients. But the number one reason why clients get referred to psychologists is because they're not adhering to their medical regimen. And like we've already talked, there's a lot of punishing behavior we're asking of individuals. So, it makes some sense. It's not like these people are out there going, not just lazy, that type of thing. Education and modeling, making sure people have a sense of social support, that friends and family members understand what these individuals are trying to do. We want to teach them mastery of these behaviors, how to do the glucometer, how to interpret the numbers, when to take oral medication, when to inject insulin. Oh, I forgot to tell you when we covered the insulin, some of the insulins are long acting. So an example would be you'd probably want to inject long acting before bed, so that it'll keep working for you all night long when you're not up and not eating. And then they come in medium acting, and then they come in real short acting. You might use, if you are insulin dependent, as an example, a short acting right before you go out and exercise intensely. So I forgot to talk about that. But how to master, this whole medical regimen. A lot of times there's grief and adjustment, just sort of grief that life will never be quite the same. If there's a history in people's families of people developing diabetes and getting sick, becoming blind, losing their hearing, having to have a leg amputated or both legs amputated, stuff like that. For a lot of individuals, kind of hearing the term diabetes means a death wish, or it means life is going to get really bad from here on out. So one of the things that psychologists have to help people do is assess their mental health in all of this, and help individuals understand that there are lots of behavioral things that they can do to try to change the natural trajectory of diabetes. That if left untreated, you bet all this bad stuff is going to happen. But if treated, if you are able to go through and get all this lifestyle stuff, then a lot of times we can save individuals. Psychologists get involved in transplant screening. So if there are somebody in need of a kidney transplant or a heart transplant, they usually get called in to help with UNOS to make the decisions on who's a really good candidate for a transplant, who will be able to take care of their body, who will be able to get the most life out of their transplant organ, who will be able to tolerate this particular types of medical regimen that somebody has to do on a transplant so their body doesn't reject the organ. All right, let's talk about blood glucose awareness training. I said at the very beginning of the lecture that our brains, and this is true, are much more sensitive to low blood sugar, detecting that, and there's evolutionary adaptation in that. We're not very good in feeling, most of us can't feel high blood glucose levels. Uh-oh, got a dog barking. It is possible, though, for people with diabetes to, especially with their glucometer and their glucose levels, to pay more attention to how they're feeling. And some individuals will start to create those associations like, oh, when my head feels groggy, that's usually when my glucose levels are riding high, because every time I feel groggy and I go and I check my glucose, you bet it's high. Or some individuals might feel like their eyesight is not clear, like it gets kind of blurry. And then they learn to realize like, oh, when I can't see real clearly, I check my glucose, my levels are high. So blood glucose awareness training is to try to train people in sensitivity for that so that they are able to maintain tighter control. Learning how to do that for a lot of people actually even helps lower their anxiety, their stress and their anxiety about their diabetes. If they can learn to detect it naturally, that's a good thing. Lots of lifestyle prevention and treatment research. So a lot of psychologists are out there doing scientific research. And then there are a different kind of psychologists. These usually aren't health psychologists. These are usually experimental psychologists that help designers that are developing technology. So like, let's say somebody has got one of those glucose or diabetes devices that they wear that's been installed. It can detect their glucose levels. It can inject insulin for them. Certain ergonomic or industrial psychologists that are working with the human technology interface. That is way outside of my area, but I just wanted to throw that in there. Okay. Now, another reason why we are talking about diabetes in the health psychology class is that we have a lot of overlap between diabetes and psychological disorders. And it makes some sense actually that these things feed each other bidirectionally. Okay, they are intertwined, but a lot of overlapping comorbidity. So meaning psychological illness that is happening at the same time for diabetes in a lot of people. So first thing, depression. We see depressive symptoms in about 21% of people with type 1, 27% in people with type 2. There is a 20% increase in anxiety disorders in people with diabetes, and there's some pretty unique issues with diabetes for some individuals. Needle phobia, I'm not real needle friendly myself, and I have to look away, and I don't like it when I get shots, and I really don't like it when I get blood drawn. But I have treated years ago when I was on my internship people for medical professionals for needle phobia. And there's a way to do that. You do exposure therapies, and it works very well if people will, comply with the treatment. Hypoglycemia, we talked about earlier in the lecture that low blood sugar is going to create that fight or flight response, that adrenaline response. And so a lot of individuals hypoglycemia will translate into a panic attack kind of feeling when it really needs to be treated medically, getting that glucose level up to a normal level. And then a lot of people with diabetes have to get these invasive medical procedures. That's certainly going to be stressful and anxiety provoking. So helping people with that. Eating disorders. We see heightened increase in eating disorders in people with diabetes. So about 6.4% of type 1 diabetes are going to have a overlapping eating disorder, whereas only 3% of people without diabetes. That would be the full-blown DSM criteria eating disorders. But the next one is going to say eating disorder behaviors. 24% of type 1 have some eating disorder behaviors. And one of the real dangerous things that a type 1 diabetic can do is to not use their insulin and drop weight really fast. Very, very dangerous medically. but it is easier to get that desired weight loss if you've got type 1 diabetes than if you're just a normal person without diabetes. And so, and I've treated teenagers who really want to lose weight quickly and abuse and don't use their insulin like they're supposed to. And that is both a medical and a psychological crisis that really needs to be taken care of. So 24% versus 10%. Night eating syndrome, about 7% of people do this night eating thing. Sometimes they're totally sleepwalking and eating in their sleep or engaging in binge eating at nighttime. And that certainly needs to be treated. So psychologists get called in for that. When it comes to very severe mental illness, so now we're talking things like bipolar disorder, schizophrenia. These are also the serious mental illnesses that drive a lot of individuals into being homeless. And then we've got some really complicated factors with homeless individuals not having regular shelter, not having regular access to medical care, may not have their diabetes diagnosed. So it's just really awful problems for some of these populations of individuals. But 29% versus 18% of people without diabetes in men. 29% have severe mental illness. And then the rates are really high for women with diabetes versus not. 60% of women with diabetes also have co-occurring severe mental illness versus 29% of women who do not have diabetes. And I've talked a little bit about the homelessness and the environment piece. A lot of times we're seeing obesity mediating, but again, even when we covered the obesity lecture, one of the things I really want to hit home that is the most dangerous is sedentary lifestyle and overeating that leads to obesity. And then the fact that many people who are obese are sedentary. I'll show you some data on this when we get to the obesity lecture, but you can have a very large body. You can be classified as obese and be eating really healthfully and exercising on a regular basis. And metabolically, your health looks nice and healthy. Okay. We'll hit that home a little bit later in the semester. This really comes down to, it's not just the body size, it's the poor lifestyle behavior oftentimes that can lead to the body size. Even interactions with medications, are people complying with their mental health medications that helping them feel well enough to be able to take care of their medical management? Just lots of gnarly interactions here for people. So some other psychological factors related to non-adherence, which is individuals that aren't doing their medical and lifestyle change regimen. Poor glycemic control is going to lead to higher levels of that A1C, that long-term indicator of bad diabetes management. An increase in the micro and macrovascular complications, which is going to add a lot of stress to people's lives. And then just the whole cost and affordability of the issue. And again, I mean, our costs for our medications here in the US are much higher than in our sister countries. Some interesting capitalism going on with that. More disability for individuals, their inability to work, let's say, because they're not managing diabetes and it's affecting their health. And then heightened mortality, just risk of premature death. So lots going on. Children with type 1 diabetes, and keep in mind that nowadays there are quite a few children getting diagnosed with type 2 diabetes. These are usually children that have been overfed really unhealthy foods, kids that are very sedentary. I'm going to feature a clip in the nutrition lecture, which is coming up next, where Jamie Oliver is with a child in a medical setting who already has type 2 diabetes as an example. So, but kids with type 1, rule of thumb is that they are managing some of their regimen, helping with their blood glucose monitoring, helping with their insulin injections, understanding how important those behaviors are in maintaining their personal health, that ideally they are working with their medical professional and they're working with their parent or parents managing some of their regimen by ages 8 to 10. Now, keep in mind, having a kid with type 1 diabetes is a formula for an anxiety disorder for any parent of a child like that. I used to be able to send my sons when they were little off to a birthday party, and they would usually come back with blue faces from eating, blue cake or whatever. And they would have, drank a bunch of Pepsi and maybe eaten pizza and ate a bunch of cake. And they would come home wired and hyperactive. And so I had to manage that. That was no big deal. But they would come home alive. A parent with a child with type 1 diabetes could go off unsupervised and in a dangerous enough environment like a birthday party could eat all the wrong stuff and go into a coma. Okay. So this stuff makes parents really anxious, and I understand that. So by age 12, before the teen years, the typical rule of thumb is that this kid is doing all of it himself, herself. Okay. And the reason for that is what we don't want is to set up a child to be able to use their type 1 diabetes as rebellion in some way. We don't want them being able to misuse diabetes for drive for thinness or eating disorders. We don't want them, if they get mad at their parents and, slam their door, lock themselves in their bedroom, not do their insulin and pass out or fall into a coma, stuff like that. So really trying to help, and psychologists do this, help move the responsibility from the parents that have been managing that early on over to that particular tweener with diabetes before their teen years. And then the family issue stuff, it just makes a lot of sense. This is going to be anxiety provoking for everybody. Okay. There's expense involved. There's oftentimes worry that this person is going to get sick and, lose their eyesight or get gangrene or need a transplant. It just makes sense that oftentimes we as healthcare providers need to get in there and treat the whole family, not just the person with the diabetes diagnoses. Type 2 diabetes in kids, this is where we're seeing a very rapid increase, and this is very scary. And this is going to have implications for our ability to afford our healthcare in the future too. Between 2001 and 2009, we saw a 30% increase in kids with type 2 diabetes. So again, remember type 1 used to be called juvenile onset. Now we're seeing type 2 as juvenile onset. It is more challenging to treat than adults. And a lot of that is because kids cognitively aren't necessarily at a level that adults might be. They don't have the resources that adults might have. And then if they don't have family support, because if you're going to be asking this kid with type 2 diabetes to eating differently, exercising on a regular basis, you're going to want everybody in the family involved in that and not just special treatment for this kid. Because if the family environment maintains unhealthy environment, this kid's not going to be able to get healthy in that environment. And we'll see when we cover the obesity lecture, I'm going to cover Dr. Lenny Epstein's research. He treats families for childhood obesity, but he treats the whole family. He gets everybody changing the way that they eat. He gets everybody engaging in lifestyle exercise. And that's the best way of doing it. What we also know is that a lot of kids out there with type 2 diabetes have very poor management of their glycemic control. So we've got a lot of wiggle room to make a difference here for these kids. Partners of people with diabetes, the financial stress we've talked about, the emotional stress of the uncertainty. Are they going to keep their eyesight? Are they going to be able to continue driving? Are they going to lose their foot? Are they going to need to go on dialysis where I have to, take them in twice a week to have their blood cleaned from the machine? Issues with childbearing. It used to be in my generation, if you had type 1 diabetes, it was oftentimes recommended that you get your tubes tied if you're a woman, and absolutely do not bear your own biological child. Nowadays, both type 1 and type 2, they're considered high-risk pregnancies, and obstetricians will treat them and monitor them much more frequently than a woman without diabetes, but it is possible to engage in childbearing. Now, they tend to have very big babies, and there's risks involved in that for mom, risks involved for C-section, risks involved in the epigenetics for that child likely having more risk for diabetes. And then what a lot of obstetricians will do in some cases is allow an individual with diabetes to bear a child, but then monitor the whole time how much risk to mom, how much risk to baby, and then sometimes offer advice that they should consider not having more children after that one child. Lots of sexual dysfunction that we talked about. We talked about the, you know, the vascular challenge of these blood vessels that stay very tiny without blood flow most of the time until sexual arousal and functioning, and then how large amounts of blood flow. It makes sense that there would be damage there. Of course, that's going to create a relationship strain. Morbidity and caregiving issues, and you know, being scared about that. Simple psychology here, when we're trying to increase compliance for people, the behaviors of compliance are not reinforced until the future. So it's like you're asking people to do all this punishing kinds of stuff now, but the reinforcement would come in the future by not being as sick. And so a lot of people psychologically just sort of live in their moments, looking for reinforcement in their moments, trying to avoid punishment in their moments. So it makes a lot of sense that a lot of people with diabetes are not necessarily adhering to their regimen. Stages of change, helping people work through their readiness for that. We're asking people to change multiple behaviors. If they're having to cope with some of the illnesses that are resulted from diabetes, like having kidney failure and going on dialysis. So lots of stuff that we can be helping people with. All right, that is the end to part 2 of diabetes. If you've got any questions for me, please post those questions to the discussion forum on As You Learn. I'll be checking that daily. Note that you can go back and, you know, review stuff in the slides. That's the nice part of having stuff online that maybe you don't get so much in the classroom. And I hope everybody's staying safe out there, and I will see you soon. Take care.